Hi, I'm Dr. James Forest-Lam, MD. Welcome back. I hope you enjoyed the talks um, that I gave previously. And for those of you who are studying, uh, using this as a tool to help with certification of the American Board of Internal Medicine or recertification, stay with it. It just has to just you just have to learn enough factoids to pass the examination. But for the rest of you, I hope you stay interested. And again, thank you for your support. Welcome back. Last time we talked about groups of diseases that cause secondary hypertension. As you recall, most people have essential hypertension, meaning that there are no identifiable causes for their hypertension. And secondary, that's different. We talked about renal artery stenosis as the first group of diseases, and the second group, pheochromocytoma. Um, the pheochromocytoma type is not as interesting somehow for the boards, and they like to talk about the familial group, which include um, which include MEN 2A and 2B, neurofibromatosis, and Van Hippel-Lindau disease. And then during my last talk, I recalled that I had a great moment. What MEN? I forgot what the MEN stood for, which of course stands for multiple endocrine neoplasia. Something you remember in your brain, in your dream, isn't it? Today we'll be talking about hyperaldosteronism, which is the most common cause of secondary hypertension, hyperaldosteronism. Hyperaldosteronism, hyperaldosteronism can be caused by one of three things. Um, adenoma that produce aldosterone, which is called Conn syndrome. When people say Conn syndrome, that's what they mean. Adenomas that produce aldosterone. And then the second one is bilateral adrenal hyperplasia of the zona granulosa cells. Uh, and the third one is pretty uncommon disease entity called aldosterone secreting carcinoma. So Conn syndrome is the most identifiable cause of hyperaldosteronism, which is the most common cause of secondary hypertension. If one considers hyperaldosteronism as a secondary cause of hypertension, one should do a screening test for plasma aldosterone and renin. If you divide the results of aldosterone by renin, aldosterone divided by renin, if it's greater than 20, that is quite suggestive of hyperaldosteronism. And in under those circumstances, you should order then a 24-hour collection for urine aldosterone after 3 days of salt uh, load. So if you you've taken an adequate amount of salt, you should have low aldosterone. But if aldosterone after 3 days of salt load, the urine collection is more than 12 micrograms, then one is considered to be strongly confirmed hyperaldosteronism. The fourth group of diseases that cause secondary hypertension or a group causing hypercortisolism, and meaning there's too much steroid in one's system, um, which can be caused by a number of the four common causes: ACTH secreting pituitary tumor, ACTH, ACTH secreting pituitary tumor is also called Cushing's disease. So that's what people that when they say Cushing's disease, ACTH secreting pituitary tumor. And then the other are um, adrenal adenoma, ectopic ACTH production, usually by some other malignancy, and iatrogenic causes, like someone who's been taking prednisone for longer than 3 months, uh, for rheumatoid arthritis, lupus, um, sarcoidosis, asthma. The presentation of hypercortisolism is that of Cushingoid presentation, Cushingoid habitus, so to speak. Um, this includes truncal obesity, moon faces, round face, purple stria, um, proximal, proximal muscle weakness, hairy, hairy presentation, hyperglycemia, and osteoporosis. There are close to a dozen uh, antihypertensive medications out there to treat hypertension. Um, I just want to group them uh, in groups so we can talk about some of the common characteristics. Um, the different groups are thiazide diuretics such as ACTH, um, and clothalidone, and loop diuretics such as furosemide, or bumetanide, Bumex. And then you have protein spare, uh, potassium sparing diuretics, the beta blockers, um, ACE inhibitors, ARB, angiotensin receptor blocker, alpha blockers. And then the calcium channel blockers has been broken down into two separate classes that are quite related, but the non-dihydropyridines, verapamil and diltiazem behave a little differently because of their nodal uh, sensitivity, as opposed to the dihydropyridine. Um, so non-dihydropyridine, there's a nodal effect. Um, they can slow down the heart rate. That is, as opposed to uh, dihydropyridine, which include phenolphine, amlodipine, which don't slow down the heart rate too much. And uh, Then there's the direct vasodilators, such as minoxidil and hydralazine. And then, as a class, used not so much these days is central adrenal inhibitors, including clonidine, methodopa, and reserpine. Then there's a class of medications that we use for treatment of hypertensive emergency, when you have hypertension that produce end-organ damage, and you just want to control it better. Nitroprusside, nitroglycerin, um, labetalol, and esmolol. Whereas the thiazide diuretics produce um, hypo uh, use of ACEI and ARBs in pregnancy. Never use it. Don't use it. It's all over the boards. And the other is that you do not use them together in any patient, um, because they both work on the same angiotensin 2 receptor. And for reasons that I cannot understand, they seem to emphasize the fact that verapamil verapamil increases the level of cyclosporin and digoxin. The first time that I learned methadopa causing cum-positive anemia was when I was a medical student. For some strange reason, they love that concept. And one should not give beta blockers to a patient who's intoxicated with cocaine or catecholamine excess, as in pheochromocytoma. That's the reason why they always say pre-surgically before you do pheochromocytoma surgery preoperatively, you give phentolamine and phenoxybenzamine, not beta blocker. And treatment for beta blocker overdoses, give glucagon. In cases of calcium channel blocker overdose, give calcium. In a patient to cardiac arrest who is also a dialysis candidate, EMD, no pulse, calcium can be used because of the high incidence of hyperkalemia in this group. Beta blockers are also not to be used uh, in cases where patients have asthma, COPD, or someone who's prone to hypoglycemia, as in diabetes, who may suffer from insulin medication induced hypoglycemia.